Evening.
Yeah.
Good evening, everybody. I think we are back for our second session on investigations in rheumatoid arthritis. And in this series, today we are focusing on the tests that we normally routinely do with reference to rheumatoid arthritis. The two tests which we do are rheumatoid factor and anti-CCP. There are still more autoantibodies which are also being described. Rheumatoid factor and anti-CCP, though we do it so frequently and so commonly, sometimes at the stroke of the hat, if a patient walks in with some joint pain, it has a lots of techniques behind it, lot of methodological issues which one has to consider before interpreting these informations and these inputs. So today, to discuss about that, we have assembled here. So today we have two speakers. First, on the technological aspect, pathophysiological aspect, and other aspects of rheumatoid factors and anti-CCP. The first speaker, Dr. Renuka, is going to deliver a lecture for 30 to 45 minutes, followed by myself. I will be analyzing on how to use and how to interpret with reference to the clinical scene and scenario. Just to briefly introduce again, Dr. Renuka is heading the Diagnostic Laboratory at Bangalore. And she has spent her more than 15 years in immunodiagnostics. Over to you, Dr. Renuka.
Thank you so much for the introduction, Dr. Chandrasekhar. Can I just share the slides now?
Go ahead, ma'am.
Visible?
Yes, ma'am. Visible.
Okay, sorry. Today I'll be talking on the autoantibodies in rheumatoid arthritis, rheumatoid factor, anti-CCP, and the newer antibodies. When you do a workup for rheumatoid arthritis, of course, we need to first establish that it's an inflammatory arthritis. Rheumatoid arthritis is a most common systemic inflammatory autoimmune disorder, which is characterized by chronic erosive polyarthritis, which involve multiple joints, and by the presence of various antibodies in the serum and synovial fluid. Genetic susceptibility, hormonal factors, environmental factors, and infections are known to trigger antibodies in the synovial of patients who are prone to develop arthritis. Then the antibodies become expansion of the milieu, the epitope spreading, isotope switching, leads to the production of pathogenic autoantibodies. These autoantibodies in rheumatoid arthritis may be present much more earlier, much more before the symptoms of the patients are seen. So that is why they are seen much earlier, these pathogenic antibodies. It's not a single antibody. Rheumatoid arthritis is a heterogeneous disorder. And it is not just a single antibody which is seen in rheumatoid arthritis, but multiple antibodies have been identified in rheumatoid arthritis, of which some of them are very, very well characterized, such as the cartilage components, there is type 2 collagen, stress proteins, enzymes like alpha enolase, glucose 6-phosphatase isomerase, and calpastatin, nucleoproteins like RA33, HNRNPA2, and cyclorelated proteins such as filigrin, fibrin, fibrinogen, bimentin, collagens, enolase, and of course, these are the synthetic cyclic peptides have also been characterized as in rheumatoid arthritis. Synthetic arthritis, of course, not seen in the synovial. When it comes to the diagnosis of rheumatoid arthritis, as I said earlier, first we need to establish that it is an inflammatory arthritis. You have to look at the clinical picture, and also to establish it's inflammatory, you may have to do inflammatory parameters like ESR and CRP. But if you look at the 2010 classification criteria of ACR, or the EULAR classification criteria for purpose of classification, which is also used for diagnosis, new criteria have emerged for the detection of early rheumatoid arthritis. Earlier in the 1986, 7 criteria, 4 of the 11 criteria had to be present, of which only rheumatoid factor was present. But later on, anti-CCP was a test which had been added. So markers such as rheumatoid factor and anti-cyclic citrullinate peptide antibodies were selected among the 5 other criteria of ACR. Let us look at what are these criteria. So you have the joints, patient having presenting with arthritis, could be involving small joint or a large joint. If it is naturally small joints, the grading becomes more. Large joints, it is 0. And more than 10 joints, it's 5. And in addition to that, symptoms, if it's more than 6 weeks, it's significant. Even if it is less than 6 weeks, if other criteria are present, then it becomes important. Similarly, the acute phase reactants. So now if you look at it, the serological markers have gained really great significance in the newer classification criteria. So if when you do a calculation, if it's more than 6 or equal to 6, then it becomes rheumatoid arthritis. What do you consider as negative rheumatoid factor, or if it is a negative anti-circulated peptide antibody? That means if it is less than the upper limit of the normal for a respective lab, it is considered as negative. For a low positive, if the rheumatoid factor is positive or anti-citrulated antibodies or anti-cytopeptide antibodies are positive, but not in very high concentration, less than 3 times the upper limit of normal, but more than the upper limit of normal, then it is considered as low positive, and it is considered as a high positive if it is more than 3 times the upper limit of normal. So if you look at it now, the rheumatoid factor and anti-CCP, if they are present in high titer, it will literally give you a score of 3. And just a presence of 1 or 2 joint involvement and a history of having mildly raised ESR or 6 weeks duration will make it into a rheumatoid arthritis. So the serological parameters or autoantibodies like rheumatoid factor and anti-CCP have gained great significance. Okay. So now looking at what do you mean by rheumatoid factor? The rheumatoid factor was the first test which was discovered in rheumatoid arthritis patients. Way back in about 1940, it was detected that there are antibody presence against the gamma globulins, and these were known to show agglutination in sheep RBCs. And when they were treated with suboptimal levels of the antibodies, and it was then realized that these antibodies are associated with rheumatoid arthritis patients in 1940. And later on in 1952, it was labeled as a rheumatoid factor because it was found predominantly in rheumatoid arthritis patients and it was being used. So these rheumatoid factors or the antibodies are produced in the inflamed synovium in the B cells in the lymphoid follicles. Whenever there is a rheumatoid arthritis patient, we see in the histopathology there is increase in the lymphoid population and proliferation of B lymphocytes. Germinal centers may be seen. So these rheumatoid factors are produced in the inflamed synovium by the B cells in the lymphoid follicles in synovium of rheumatoid arthritis patient, and it is an antibody which was found that react to the FC portion of the polyclonal IgG. So if you look at the pathophysiology, it is known that rheumatoid factor is not just detected, but may also have a role in pathogenesis of pathophysiology of rheumatoid arthritis. What happens is when there is high inflammation, then high affinity and high titer rheumatoid factors induce the formation of immune complexes at the site of synovial inflammation, activation of the complements, as well as the leukocyte infiltration. The B cells, which are already produced with the inflammation, with rheumatoid factor specificity, then migrate into the synovium, presenting a wide variety of antigens to T cells, and this in turn may contribute to the perpetuation of the local inflammation response and amplification of a rheumatoid factor in the synovium. So if you look at it, the rheumatoid factor itself may prolong B cell survival and hence maintain its own production. So as I already mentioned, rheumatoid factor is an autoantibody that reacts to the crystallizable fragment portion of the polyclonal IgG, but they can be of any class. So it's basically, it can be of IgG, IgM or IgA class, but most of the assays which we did use for detection of rheumatoid factor are detecting IgM. How do you do this test? These tests could be done either by latex agglutination, immunoturbidimetry or nephelometry. It is basically an antigen-antibody reaction, which we are looking at. And what we used to earlier do used to be the latex agglutination assay, but now these are outdated, but they're very easy to perform. What you just need to look at is when you put in a slide, you add the serum and you add the latex along with the antigen, and you see for agglutination. So these have been now replaced by automated methods like immunoturbidimetry and nephelometry. Nephelometry, of course, is you require a separate instrument where you measure the light. Whenever there is an antigen and an antibody reaction happening over there, you use the measure the light which is scattered after striking a solution. And that is calculated wherein you keep the photodetectors usually at a 90-degree angle or at a 135-degree angle in a nephelometer. This requires a separate instrument which is called as a nephelometer. But the advantage of it is that it is automated and you can detect various levels over there. And turbidimetry is a measure of is also a method which can be used for detection of these autoantibodies, wherein here the photodetectors are not placed at an angle, but rather in a straight line, and you look at the reflected light depending on the antigen-antibody reaction. So you measure the cloudiness of the solution based on the reflected light and then indirectly calculate the scattered light over there. So that is the difference between a turbidimetry and a nephelometer. The advantage of doing turbidimetry is that you can use your routine biochemistry instruments for doing the immunoturbidimetric measurements. Why we prefer the nephelometry or turbidimetry over the latex method is, first of all, it is highly automated. It gives you the assay can be done very fast, simple to operate. Once the instruments are, of course, calibrated, QCs are measured, and calibration is done. So what here we actually do in an assay, when we are doing calibration, we mean is we take a reference standard, usually a W1006 is used for rheumatoid factor. There are available WHO reference standards. So you take a reference standard and there will be traceability done to that. So we don't have a standard, but we'll have a traceable standard. And these standards, against this standard, you measure the antigen antibody concentration, do multiple dilutions and set up a standard curve. And then once you get the analyte, you get a sample, you measure it against the standard and against the curve, and you get to the calculation. The advantage is to get exact values, which are usually expressed in IU per ml or IU per liter, depending on the range which you accept and the equipment which you are using. Small sample and reagent volume is required, and it has a very high sensitivity. The only disadvantage is that the background scatter, particulate matter, lipids may sometimes interfere, which could otherwise also interfere. Turbidimetry usually requires large particle concentration. But what also happens is there will be a limit to the linearity when you do turbidimetric instruments compared to the nephelometer. And nephelometer, of course, gives you very good graphs and it gives you good values as well as the turbidimetry, but it needs a specialized instrument. The other thing is, suppose now let us just look at, if you were using, you might feel that when you do a latex agglutination, you do a titration. So you say it is positive in 1 in 40 titer or a 1 in 80 titer. And then suppose now the patient is rheumatoid factor positive and has a very high titer of antibody. You may, in spite of having a high titer, you might realize that the patient is giving a negative result on a latex agglutination. That may happen because of a frozen phenomenon where there is an excess of antibody which is present, which might give you a negative reaction in spite of having a high antibody level in the serum. So you might still get a negative reaction. So all this can be avoided when you do multi-point calibrations in immunoturbidimetry or nephelometry, because there we use various standards and then you can give the results in IU per ml or liter. Depending on that, the reference ranges will change. Most of the time, rheumatoid factor is taken 25 or 20 is taken off as the cutoff for negative or positive for most of the immunoturbidimetry or nephelometric assays. And this is usually based on the 1987 criteria which were established. Rheumatoid factor is present in 75 to 85% of established rheumatoid arthritis, but may be absent in early 5 months and appear with persistence of synovitis. So that means in the initial period, as the disease progresses, it might be present, may not be present in the initial factor in the initial period, but it's also known that it has been detected in patients months or years before the onset of clinical symptoms of rheumatoid arthritis. And the presence of rheumatoid arthritis factor is associated with a 20 to 40 fold greater risk of developing rheumatoid arthritis. However, the risk is relatively high in those with very high titers. But as I said, this does not happen with all cases, and it is found only in 40 to 50% of early rheumatoid arthritis. Not just that, rheumatoid factor is not very specific and may be present even in the general 5 to 15% of general population. And it's quite not specific, found in other autoimmune disorders like lupus, scleroderma, mixed connective tissue disorders, as well as other hepatic and pulmonary disorders, neoplasms, radiation, chemotherapy, sarcoidosis. All this might give you a false positive rheumatoid factor assay, or there could be an elevated rheumatoid factor. So that means it's not very complete. So what we need to do was another antibody was looked up, and the other antibody this was the anti-CCP. One thing I forgot to mention was rheumatoid factor is a good prognostic marker. A very high titer of rheumatoid factor has been found to be associated with more aggressive articular disease, increased disease activity, reduces the rate of remission when you're treating. There is a high prevalence of extra-articular manifestations and increased morbidity and mortality. About 20% of RA patients are seronegative for rheumatoid factor, as I've already mentioned. But let me tell you, though the titer has indicates a worse prognosis or a more severe disease, it has no relevance for the follow-up of the disease activity and is not used as a marker for monitoring the disease. Rather, inflammatory parameters are used for monitoring the patients with rheumatoid arthritis. As I said, the interesting thing which was developed in the late 90s, or rather I should say in 2000, was the anti-citrullinated peptide antibodies. The characterization of autoantibodies reacting with the citrullinated peptides in rheumatoid arthritis was first reported in 1998 by the Van Menergis group. They noticed that there is antibodies, when you looked at under the immunofluorescence microscope, about in 1964 actually, anti-perinuclear factor was seen, and then anti-keratin antibodies were also identified. And these were related to citrated protein filicrin. Later on, it was also noted that there was antibodies towards vimentin, so which is also called as which is related to the citrullated vimentin antibody. So a combination of all of this vimentin, perinuclear, anti-keratin, and it was noticed that these are all citrullinated proteins, and these are produced by plasma cells in RA joints. And during the inflammation, citrullination occurs, which seem to play a role in autoantibody production. So several citrullinated proteins can be found in RA synovium. However, fibrin is because it's a degradation product, is a major citrullinated protein in rheumatoid arthritis patient. Let us look at the potential mechanism of how anti-CCP formation works in rheumatoid arthritis. The epitope of the antigen is the arginine residue, which are converted or citrullinated by an enzyme, that is the PAD enzyme, or arginine deaminase enzyme. They arise in the course of local inflammation. These are processed by the antigen-presenting cells. The antigen-present cells with a shared epitope with the MHC molecules bind the citrulline with high affinity and present these to the T cells, which leads to activation of additional T cells by the clonal expansion of the T cells and cell-mediated immunity against this citrullinated antigens. Besides these T cells, the activated T cells also stimulate the B cells reactive to the citrullinated peptides are activated, and they cause production of the antibodies or the anti-CCP antibodies. Now, what do this anti-CCP bodies? So when you look at the pathogenesis, whenever there's an inflammation, there is an increase in the infiltration of the immune cells, which contain the PAD enzyme, and there is increase in the calcium concentration, which leads to the citrullination, as I have already described over there in the earlier picture. And then these, in turn, these antibodies which are form immune complexes, lead to the upregulation of the pro-inflammatory cytokines. They also react with the osteoclasts, bind with the osteoclasts, leading to resorption of the bones and erosions. causes leukocyte activation and netosis and net formation and enhancement and complement activation. But the factors like it has been noticed, the genetic factors such as the shared epitope with HLA-DR1 is associated with increased anti-CCP levels, as well as environmental factors such as particularly smoking is known to be associated with the increase in the citrulated peptide antibodies and hormone levels, and possible contribution is also known of bacterial PAD enzymes which lead to the formation of this pathogenesis process. So if you see this as little independent and different from what you saw in the rheumatoid factor. So citrulated peptides have been used for detection of these antibodies, and these have been synthesized as antigens for diagnostic immunoassays. The most common or the earlier test procedure which was earlier done was the ELISA. So CCPs were available earlier in linear form, then they went upgradation to a cyclic form. I'll just describe that. And the first cyclic ELISA assay was available in 2002. And it is known that CCP peptides, CCP2 ensures detection of a broad range of antibodies to situated host proteins and proved to be extremely specific. As I said, the first assay which was marketed in 2000 was anti-CCP1, which used a defined peptide from a filigreed epitope and used as a citrulated antigen in rheumatoid arthritis. And they used a linear form. So this had a comparatively lesser specificity, and a modification was done, and simply they were formed into cyclic form from the linear one, and synthetic peptides were produced, and a synthetic, and basically anti-CCP2 is nothing but a synthetic set of peptides which were used by screening about 12 million peptides of the synthetic library was incorporated into the assay, and they are denoted as cyclic form of citrulated peptide. So it is the version 2 is the CCP2 is the cyclic form of citrulated peptide 2 is the cyclic form. Now this proprietary product was then licensed, and many diagnostic companies were given this to produce the anti-CCP2 assay. However, there was one manufacturer who developed their own cyclic peptide, and they denoted it as CCP3, which was distinct from the one which was developed from the CCP2. And here also, of course, ELISA test was used. So CCP2 and CCP3 were in a way, performance-wise, quite similar. A further development, a German was done in a German company, found a further development of by detecting antibodies to naturally citrulated pimentane, so which is also called as the SA antigen. So though this particular SA antibody or anti-MCV had a very high specificity, it showed a very low diagnostic sensitivity with only about 31 to 44%. Whereas anti-CCP had definitely much more higher sensitivity. So finally, most of the products that we use are currently the anti-CCP2, which has a reasonably good sensitivity and also very high specificity. These are most of the assays are based on the CCP2, and usually they detect the IgG citrulated peptide antibodies. IgA and IgM anti-CCP citrulated peptide antibodies are primarily developed for research purpose. Only thing is the anti-CCP3 manufacturers also came up with one more version which is called as anti-CCP 3.1, which used as a conjugate which detects both the IgG and IgA. However, studies indicate a good agreement between CCP2 and CCP3, and there was not much of a variation which was found. So both of the things can be used equally. The method for detection, as I said, was the ELISA, which was used for the CCP assay. But now, because of the ease, better sensitivity available, and as well as for automation and the speed, and that the results should be available faster, these were also have been established on the chemiluminescence immunoassay platform. And there is also one assay which is a Luminix-based assay. So many of them are now shifting from the ELISA to the chemiluminescence. Both are equally good. Mind you, I can tell you one thing, but however, the reference values for CCP in most of the ELISAs is say a cutoff of 5, whereas chemiluminescence, some companies use a cutoff of 17, some use a cutoff of 5. There is a variation, and there is a variable numerical cutoff, as there is no commonly used international standard for the anti-saturated peptide antibodies, though there are available, but there are two different types which are available. A few different types of standards are available, because of which we do not have the thing. But however, when you look at one-on-one on each instrument, you have to do a standardization and validation for your equipment, and the dilutions which you use of the conjugate on your instrument are important, and you have to establish the reference value as for your instrument. That is why if you look at the ACR criteria also, it does not give an exact cutoff value. It says upper limit of the normal range for a negative or a positive. So it does not give a definitive or an exact value for an assay, because all of them are acceptable. Anti-CCP antibodies are locally produced in the inflamed joints, as I've already mentioned. They present much more before the symptoms develop, frequently present because early in the course of the rheumatoid arthritis. It does not get affected by, it is much more specific than rheumatoid factor, and it is not affected by infections like hepatitis C and other autoimmune disorders. When we looked at, we had done one study, of course, where we had looked for the role of anti-CCP in a South Indian population in 2006. This was much way back, once about 3 to 4 years after this assays came into the market. And we looked for early inflammatory arthritis and examined about, which were reviewed by the rheumatologist, and which were rheumatoid factor negative, and they were followed up for a period of 3 to 6 months. And we found that it had a sensitivity of about 63% and a specificity of 96%. It was derived that anti-CCPs are highly specific tests for detecting rheumatoid arthritis in patients presenting with suspected RA in early stages, and it supplements the testing of rheumatoid factor. So now that is why both of them are, of course, not just because of this study, but it has been studied all across, that it is definitely a very useful assay for rheumatoid arthritis, one of the best currently available, with a sensitivity on par with that of rheumatoid factor and a specificity which is much, much higher. However, it does not detect all the patients of rheumatoid arthritis. Let me be very clear over here. So anti-CCP is a prognostic marker, is also present before the symptoms develop, which we have already mentioned. It is associated with development of erosive arthritis. It helps in predicting which patients will have a persistent disease and erosive disease, as well as it decreases with remission induction and increases with disease expression. It does help to some extent. Still, it is not to be used for monitoring, and the presence of anti-CCP has a very high prognostic implication. So it is useful in diagnosis, it is useful in prognosticating, and it's important in the pathophysiology and understanding the pathogenesis of the rheumatoid arthritis. These are the two major antibodies, the rheumatoid factor and the anti-saturated peptide antibodies, or the anti-CCP, which are currently present in the diagnosis in the classification criteria for rheumatoid arthritis in 2010. Since, as I said, there are still many patients who could be anti-CCP negative, and we have patients who are, the presence of anti-CCP indicates a more aggressive disease. We do have arthritis patients which are called a seronegative arthritis, which may be rheumatoid factor or anti-CCP negative arthritis. So what do we do then? We need to have other antibodies. So various autoantibodies were studied. And there is one new interesting autoantibody which is there, that is the anti-carb antibodies, or antibodies against the carbamylated proteins, that is, that contain the hemocitrulline residue over here. It is also a post-translation modification in which a positively charged amino acid lysine is replaced by a neutral amino acid, that is homocitrulline. So in anti-CCP, if you look at the pathogenesis, it was an enzymatic reaction which was done by PAD. Here, it is a non-enzymatic chemical reaction involving cyanate in the conversion of lysine into hemocitrulline. And where do you get this cyanate? Is most carbamylation believed to take place under inflammatory. Whenever there's an inflammation, there is a release of myeloperoxidase by the leukocytes, and these convert the thiocyanate to cyanate, an essential driver for the carbamylation of this protein. These are detected in about 45% of patients with rheumatoid arthritis and may occur it has been found in 16 to 30% of the anti-CCP negative patients. So yes, this will help us. Seem to be associated with more severe radiological progression in anti-CCP antibody negative RA. Its presence in RA patients is associated with a more severe joint and even in those who do not have anti-CCP. It might be a useful biomarker to identify the anti-CCP negative or the citrulated peptide negative patients of rheumatoid arthritis or the pre-RA patients and newly diagnosed who require early and aggressive clinical intervention because they are known to have a more severe radiological progression. So it can be detected. Not just that, the advantage of anti-CAP antibodies is that it can be also detected in juvenile idiopathic arthritis. Though it is not in a very high incidence, still it is much better because anti-CCP is positive only in 2 to 12% of juvenile idiopathic arthritis, whereas anti-CAP are represented much more. This is about 30% of cases will have anti-CAP antibodies. So independently as such, they will not be useful for a diagnosis. But if you add anti-CAP antibodies to the rheumatoid factor and anti-CCP, it might help us in increasing the sensitivity. Because as we have already said, sensitivity of rheumatoid factor is also low, around 64 to 65%. Even CCP is also low. Combined, of course, it's much higher. And it will increase if you use the anti-CAP antibodies. Besides that, there are other antibodies like PAD4 antibodies, which is again, as I said, peptidyl arginine deaminase, that enzyme which we used, which was seen in citrination of anti-CCP, a calcium-dependent enzyme, one of the proteins that is responsible for arginine into citrulline, and it is present in 22 to 45% of established patients and have been associated with severe disease, but it is having a low specificity. The prevalence and extent of interstitial lung disease was, however, found to be higher among patients with PAD3, PAD4 cross-reactive and may serve as a biomarker for disease prognosis, particularly in cases of interstitial lung diseases. Anti-BRAF antibodies, these are non-specific antibodies seen in rheumatoid, but has been positive in patients who are anti-CCP negative. So, though they had tried again over here, a study was done to see how do they to take up those patients which were anti-CCP negative. Anti-Ra33 antibodies is again not a very sensitive. Here, as I said, BRAF was not specific, but anti-Ra is not a sensitive test. But Ra patients with, rheumatoid patients with Ra33 antibody positivity had a less aggressive course. So the presence of a Ra33 antibody was a good prognostic indicator. Anti-malonidaldehyde and anti-malonidaldehyde acetaldehyde antibodies were found to be associated with cardiovascular problems in rheumatoid arthritis. Besides this, there are other antibodies like antioxidized antibodies present, protein antibodies, which will have look for superoxide acid. And high titer with anti-ROS C2 reactivity was observed in early RA, regardless of the status of citrulated peptides, and they had a very high sensitivity. However, most of these have only been used for research exercise, and none of them have really been found to be independently good tests for the diagnosis of rheumatoid arthritis. So, to just sum up what we have discussed today, that rheumatoid factor and anti-CCP are definitely very remarkable antibodies currently used in the diagnosis and provide clinical as well as pathological information. They form the classification criteria for rheumatoid arthritis. Anti-CCP antibodies are detected early and are more specific and has high predictive value for rheumatoid arthritis development compared to rheumatoid factor. A high titer of either anti-CCP or rheumatoid factor is associated with severe and erosive disease. So it is a very good prognostic indicator, but not very useful in monitoring, though it has been found that sometimes these antibodies do come down after treatment, either with infliximab or other monoclonal therapies which are being used now. The detection of anti-CAP antibodies in rheumatoid factor and CCP negative cases may increase the sensitivity. So probably we can add another antibody to increase the sensitivity. However, as I said, these assays, it's not just important that we do this test, we will also need to understand the pitfalls of each assay procedure, and a little bit of harmonization of the assay procedure has to be done, and cutoff values is necessary so that there is a clear understanding of this test. And All this just indicates that rheumatoid arthritis is a heterogeneous disease characterized by the presence of many antibodies, though we are in search of definitely the one good marker which is not available. We could probably work it up by using a combination of 2 or preferably now 3 antibodies in the diagnosis of rheumatoid arthritis. Thank you so much.
Thank you, Dr. Renuka. I think now we will move on to the second session before opening it for the Q&A. I think in the second session, I will be discussing about the how and when to use rheumatoid arthritis as a test. Is my screen visible?
No, it's not.
Okay. Sorry, I think there is some small technical issue. Yeah, I think now it's visible. Okay. The question that comes to all of us, I think you heard, having heard Dr. Renuka, that she did mention that the rheumatoid factor and anti-CCP can be present sometime even in normal individuals, or sometime even much before the rheumatoid arthritis develops. So now the question comes to us is, when all we can ask for rheumatoid arthritis, rheumatoid factor or anti-CCP? What are the clinical scenarios where one should ask for these 2 tests? Unlike screening for diabetes, unlike screening for hypertension, you can't just ask for this rheumatoid factor and anti-CCP as a part and parcel of a master health checkup. For varieties of reasons, I will dwell on that, why one should not ask, what the confusion that we get in if we get a test which is otherwise could be falsely positive. The usual scenarios where most of us ask the question, ask this rheumatoid factor as well as anti-CCP are when the patient presents with polyarthritis or oligoarthritis, and very rarely when they present with monoarthritis. Again, duration matters. If the patient has pains and aches in multiple joints or few joints for a shorter time, like a week or 2-3 days, in my best opinion, it's best not to ask for these tests. Look for any other possibility of these pains and aches and try to work on through for differential diagnosis. If the arthritis, either polyarthritis or oligoarthritis of more than 3 to 4 weeks of duration, that's a point of time when one should start thinking of asking for rheumatoid factor or anti-CCP or any of the tests which is relevant for making a diagnosis of inflammatory arthritis. So you need to be very clear that the patient has an inflammatory arthritis, polyarthritis or oligoarticular presentations, and that's a point of time where we may ask for a rheumatoid factor and or for anti-CCP. In monoarthritis, most often if it is a short duration involving within knee or a larger joints, and if it is having a severe high-end inflammatory symptoms like red discoloration, very severe tenderness, severe pain, possibility of septic arthritis is higher, and in that condition, asking for rheumatoid factor may not of much help. Presence of deforming arthritis is another area where one should ask for rheumatoid factor and anti-CCP. Presence of dry mouth, dry eye, scleritis, one need to think twice, but asking for rheumatoid factor and anti-CCP may help you. Patients with are especially elderly with shoulder and limb girdle pain. I will tell you how it's going to be helpful. Positivity tells you something, negative is going to tell something. If borderline positive, then you are in a confusion what to do with that particular report. Arthritis with a skin disease, psoriasis, or any other conditions, you may have to ask for rheumatoid factor and anti-CCP. Vasculitis, especially small vessel vasculitis with joints pain, rheumatoid factor and anti-CCP may help you to take a reasonable conclusion with reference to rheumatoid arthritis. Interstitial lung disease, where you are suspecting a possible associated connective tissue disease, or the pattern is unusual to classify into any of the NSIP or any others, one can consider possible rheumatoid lung or a rheumatoid associated interstitial lung disease. You can ask for rheumatoid factor. So you need to be very clear. So whether the test is going to help you with reference to the diagnosis that is in question. So that's why in the order of preference, we would like to have the patients with polyarthritis or oligoarthritis of a duration more than 4 weeks to 6 weeks, monoarthritis of a longer duration, deforming joints, presence of dry mouth, elderly with shoulder limb girdle, arthritis with skin disease. Necessary for using these tests becomes lesser, but one need to use carefully about the tests. So why should we be careful while asking for a simple test like a rheumatoid factor as well as for anti-CCP? I mean, there is a latest published guidelines from Swedish. It's a very interesting guidelines on musculoskeletal disease health and when and where to increase. So they have made a very nice clear-cut guidelines. In a situation where positive probability of RA is less, do not ask for rheumatoid factor or do not depend on rheumatoid factor alone. Why and what does it mean? Because rheumatoid factor could be positive in 5% of normal population. That being the case, when you are not sure that the patient has rheumatoid arthritis, the rheumatoid factor is going to mislead you rather than going to help you. For instance, patient has an inflammatory back pain. You ask for rheumatoid factor. Rheumatoid factor comes at a line something like 50 plus, 55, 60. You really do not know whether this rheumatoid factor is responsible for whatever the problem he has. Certainly, a person with an inflammatory back pain with no peripheral arthritis, your first possible diagnosis is an angstpond or an inflammatory back pain related spondyloarthropathies. In that case, rheumatoid factor is not going to lead you to the diagnosis of rheumatoid arthritis, and even if it is positive, you should not conclude the diagnosis as rheumatoid factor. But in a scenario or in a situation where you are doubtful, possibility of rheumatoid arthritis is not very sure, not very clear, a sort of atypical presentation of rheumatoid arthritis. I would like to recall the slide presented by Dr. Renuka, where our paper where we have tried to work on in that scenario was in an atypically presenting rheumatoid arthritis, if I do anti-CCP, is it going to help? Certainly yes, because anti-CCP has a specificity of 90 to 95%, though its sensitivity is lesser. A positive anti-CCP will lead you to a reasonable strength to conclude it as a possible rheumatoid arthritis. Anti-CCP also being more specifically seen in rheumatoid arthritis with a specificity of around 90 to 95%. Positive anti-CCP antibodies, even in an atypical clinical presentation, should give us a reasonable assurance to conclude the diagnosis as rheumatoid arthritis. It's also been mentioned that sometimes anti-CCP and anti-CCP could be present even in pre-RA, before the patient develops into rheumatoid arthritis. So that being the case, presence of a positive anti-CCP and anti-CCP more likely will substantiate even in a patient who are otherwise atypical in its clinical presentation, in contrast to rheumatoid factor. In rheumatoid factor, the major challenge that for us is, since it is present in quite a good proportion of other autoimmune disease, and also being present in a 5% of normal population, and its specificity being on the lesser side, it's around 55 to 60%. In a scenarios where probability of RA is less, think twice to ask for rheumatoid factor, and if it is positive, again, think twice to conclude the diagnosis as rheumatoid arthritis. It suggests that imaging can be added as an additional test to determine the diagnosis, and it prefers the imaging technique in an atypical presentation over rheumatoid factor. I mean, this particular guidelines is very interesting for us to analyze and for us to understand that when you are asking or interpreting a rheumatoid factor, your positive probability of rheumatoid arthritis should be reasonable. It should be reasonably good, and that's a point of time when rheumatoid factor alone can help you to conclude the diagnosis. So that being the case, in a scenario where you're not sure of the diagnosis, whether it is rheumatoid arthritis or not, asking for both rheumatoid factor and anti-CCP will be more better in a more better scenario or in a better stage where you can reasonably conclude a diagnosis of rheumatoid arthritis. So coming back to the scenarios where the rheumatoid factor can help us to make a diagnosis, where all the rheumatoid factor has been used as a criteria for making a diagnosis. It is used in two different scenarios. One, when it is present, it is given a score. In another scenario, when it is absent, it is given a due importance. For example, in the columns on the right side, where if it is present, positively present, it gets a positive score. In rheumatoid arthritis and ACR-ULR criteria, presence of rheumatoid factor and presence of anti-CCP, either of them or in together is given due significance. Again, here even the titers are given due importance. If it is on the lesser titer, we score 1. If it is on the higher titer, we score 2. Similarly, in cryoglobulinemic vasculitis, it is used as one of the minor criteria. Presence of rheumatoid factor is considered as one of the minor criteria for making a diagnosis of cryoglobulinemic vasculitis. Scleritis without MSK symptom, positive rheumatoid factor and anti-CCP can be used as scleritis probably associated with rheumatoid arthritis, which is likely to develop over a period of time. See, here the positive test is going to help you to conclude a diagnosis. Similarly, a negative test also will help us to take a conclusion. For example, in psoriatic arthritis, in Casper criteria, absence of rheumatoid factor or anti-CCP is scored 1. So if it is negative, if rheumatoid factor is negative, if anti-CCP is negative, it gives a score of 1 to take a reasonable diagnosis of psoriatic arthritis. So factor negative, and if you have dactylitis, if you have nail changes with minimal joint space, you get a good score to make a diagnosis of psoriatic arthritis. Again, in Still's disease, absence of rheumatoid factor is also given a score 2. So they will give a score of 2 in the absence of rheumatoid factor to call it as Still's disease. Similarly, in polymyalgia rheumatica, absence of both rheumatoid factor and anti-CCP helps you to conclude it as a polymyalgia rheumatica. So the same test, rheumatoid factor, presence it gives a clue and becomes a part of the criteria in making different diagnoses. Similarly, an absence of that is going to help you to conclude some of the diagnosis based on the criteria score. So when it comes to anti-CCP, it is only present in rheumatoid arthritis, and it is specific. When it is present, you make a reasonable conclusion to call it as rheumatoid arthritis. I hope you understood the importance of the two tests. Rheumatoid factor, when it is present, when it is absent, it makes a matter for us in differentiating two other conditions. When it is present, when you are not probably suspecting any of these diseases, it may not help you at all because it could be there as a part and parcel of a 5% of a normal population. So you need to be careful. You need to be very clear. Why do you want that test, whether to include or whether to exclude a diagnosis? So is it useful in conditions other than diagnosis? I think I dwell on how to use it as a diagnostic tool. Is it really going to help it? I think regarding monitoring, it's been told very clearly, it may not be a useful tool for monitoring the diagnosis, monitoring the activity of the rheumatoid arthritis. The reason is the fluctuation of anti-CCP and rheumatoid factor do not match to the disease activity. The titers may be very high, the patient may not have disease activity, and you may have a seronegative patients where the titers are 0, but still patient may have a severe and an aggressive disease activity. So it's not going to be useful as a monitoring in a given set of circumstances. But in a patient as a follow-up titers, it can help to some extent whether patient is responding adequately to the therapy. But we don't use it because you will have to have a baseline value and it should be tested in the same method, and the mechanisms and the standardization should be same. And with so much of variability in reporting and so much of variability in standardized techniques, it may not be a useful tool in monitoring the disease activities. Whereas, is it helpful in predicting the response and outcome? I will deal with it in details in further. Yes, high titers of rheumatoid factor, high titers of anti-CCP suggest an aggressive disease, and their response to some of the drugs are different when it is negative, when it is positive, when it is in higher titer. It also, can it help in typing the pattern of biomarkers? I think we recently published in one of the news and views that the presence of antibodies suggests a one type of rheumatoid arthritis, absence of antibodies suggests another type of antibodies. Probably as we understand and analyze the spectra of autoantibodies, whether a rheumatoid factor ACCP positive, rheumatoid factor ACCP double positive, ACCP positive with rheumatoid factor negative, it has been shown that pathological process in the synovium, pathological process in the T cell, B cell regulatory processes are very different. So that being the case, probably with the understanding and analysis further, we may be able to use these antibodies as a biomarker and to type the pattern of rheumatoid arthritis. Does it help as a marker for sustained remission? Answer to that question is still not answered. I mean, there are few studies which clearly shows that the drop in titers of rheumatoid factor, anti-CCP regression helps us to suggest and predict a possibly long-term sustained remission. Patients who are absent in the very beginning, who have a rheumatoid factor being absent, anti-CCP being absent, who achieves a remission are likely to have a long-term sustained remission. Patients who are otherwise positive, moves into a negative status, are likely to have a sustained remission, but the data are still not adequate to conclusively call for it. But certainly, if you look from the pathophysiological and immunological perspective, probably this particular change may be a good indicator of that. So regarding prediction, there is a well-synthesized table published by Ronaldi et al. In recent publications in 2021. You could see that when it comes to the response to TN inhibitor, these anti-CCP and rheumatoid factor are of no predictive value. Don't help us in whether the response is adequate or not. When it comes to IL-6 inhibitors, there is a conflicting evidences. Some say yes, that high titers of rheumatoid factor and ACPA have a better efficiency, whereas there are many studies which suggest that probably it is not that good. But I think we have to still wait for still more larger trials and studies to conclude that. When it comes to abatacept, there is some evidence which suggests that only isolated ACPA positive, especially in the early course, have a good response to abatacept. And rituximab, I think we have seen that patients with high titers of rheumatoid factor and ACP positive have a better response. And in JAK inhibitors, there is, as it stands now, there is a better efficacy in seropositive as compared to seronegative patients. With reference to baricitinib, we don't have enough data, but there is no good predictive values. So you could really see that the presence of a rheumatoid factor and ACPA favors to choose the drugs like rituximab, JAK inhibitor, and ACPA positivity possibly should help us to choose an abatacept. So it can grossly give a guidance currently to personalize the medicine, personalize and pick and choose the disease-modifying anti-rheumatic drugs, especially biologic DMRs. So thus, in an established rheumatoid arthritis, rheumatoid factor and anti-CCP can give you some more clues. For example, if the titers are higher, in rheumatoid factor, you have a more extra-articular manifestations, and it is usually aggressive and erosive disease. And the level of rheumatoid factor could parallel the disease activity to some extent. Rheumatoid factor positivity possibly predict a good and a better response to rituximab and tocilizumab. Similarly, in anti-CCP, you have a more structural damage, radiographic progression is worse, and it has a poorer response to therapy, and it is best to handle them with an aggressive triple drug regime, because combining methotrexate, hydroxychloroquine with leflunomide or sulfasalazine is supposed to have a better benefit in a patient who are ACPA positive rheumatoid arthritis. And ACPA positivity, again, as I showed in the previous table, shows a better response compared to the negative ACPA group. So anti-CARP antibodies and other antibodies, they are still under the evaluation. I think hopefully down the lane, we should get adequate literature with reference to these newer antibodies, should help us that this may be of a greater help in typing and personalizing the things. As Dr. Renuka suggested and presented, the more severe joint damages are seen in anti-CARP, and it can also be seen especially in a negative ACPA patients. Abatacept seems to be of a good benefit in the patients who are anti-CARP antibodies. Another clinical scenario where we have a doubt, is these autoantibodies helpful? Can it be, or can it be used as a screening test in a patients who are likely to develop rheumatoid arthritis, or who are likely to move into develop a rheumatoid arthritis? None of these autoantibodies alone are currently recommended to be used as a predictor or a screening test for predicting the rheumatoid arthritis, because predictive possibility is not that better, or not so accurate, or not so specific and sensitive. Using them and putting a patient into a possible drugs like disease-modifying anti-rheumatic drug, or putting him on the watch list, is going to cause more psychological stress than really going to be useful with the available current standard of treatment. But certainly there are studies which shows that a clinical screen questionnaire like early morning stiffness, squeeze sign, and some of these positive signs along with a screening for autoantibodies, one can pick up or predict a rheumatoid arthritis development earlier in the course of the time. So in a nutshell, what we are now looking is, we are trying to work out with reference to these autoantibodies. In the initial stage, we thought it's only a diagnostic test which will help. And slowly we are trying to understand from the available data, yes, it can help us to identify the group of patients who are likely to have an aggressive disease, a group of patients who are likely to respond to some specific group of drugs. And over a period of time, hopefully, with the improvement in understanding and available data, we may be able to personalize the treatment option using these autoantibodies. Thank you very much for patience here. Now the session is open for questions. I think all of you can switch on your videos and join for Q&A sessions.
Sir, this is Dr. Shruti here.
Yeah.
Sir, thank you for you and to Dr. Renuka ma'am. It was a very nice presentation. The question is, sir, do the antibody titers, do they have any predilection for extra articular manifestation, especially ILD, sir?
Yeah, I think Dr. Renuka.
Yeah, I mean, they can have more aggressive and severe course of disease if there is a very high titer of antibodies, both rheumatoid factor and anti-CCP. So not only the erosive disease, but they can have extra articular manifestations, could be more in those who have got very high titers of antibodies.
There is little of bifurcation in that, especially rheumatoid. Yeah, rheumatoid factor, when they are on a higher titers, usually they suggest like rheumatoid nodules, rheumatoid vasculitis, neuropathies. Those are little more higher. And ACPA in higher titers, interstitial lung diseases are higher. Again, anti-CARP antibodies are also has been associated with higher incidence of interstitial lung disease, because anti-CARP and anti-CPA are supposed to originate from the lungs. I mean, there are studies which says that these autoantibodies are seen much earlier in the sputum and the bronchoalveolar lavage than on the synovium. So probably it suggests that they have an increased tendency in these patients with higher titer of these autoantibodies to involve the lungs compared to the rheumatoid factor. But of course, even the rheumatoid factor high titer also have increased
Rheumatoid factor
incidence.
also has more extra
Manifestations.
Not specifically ILD.
Okay. Ma'am, at any point we'll be doing anti-CCP antibodies now?
Yeah, we are actually, I have ordered for the kit. I'm looking at up more of research kits are available, but there are a few kits available. Not yet started. Probably before we start, we'll also be doing the validation completely, do some comparison, and then we'll go ahead. But very soon we should start, maybe in a month or so. Within 1 month, I think it should be available completely.
What will be the method for it?
ELISA.
ELISA.
Yeah, Dr. Amla.
Yes, ma'am. Ma'am, anti-CCP antibodies, you were saying that specificity is high, no, ma'am. What is the sensitivity if we take individually as a test? Anti-CCP?
See, the sensitivity is individually is not very high. It's only about I think,
Sensitivity is low.
yeah, but but it is positive in those cases which are anti-CCP positive. That is why I think the sensitivity is not very high. You cannot use it single antibody for detection of the cases. So you have to do it as a combined test along with your rheumatoid factor and anti-CCP. Then your overall sensitivity will increase.
Okay. Overall, just
Overall
with that test, it will increase.
Because it will pick up those cases which are not being picked both by rheumatoid factor and anti-CCP. That is how your anti-CCP sensitivity will increase. As a single independent test, it will never replace your current anti-CCP or rheumatoid factor.
So its sensitivity is low.
Yeah.
Sensitivity is quite low.
Sensitivity is low.
Okay. Thank you.
Yeah, yes, I think any other questions?
Sir, you mentioned that if based on the antibody sensitivity, some of the drugs are more effective, like rituximab or tofa. So once we give them a rituximab, do you have to measure their antibody titers to see the response routinely?
See, it is not currently used routinely, and there are research work which are going on how to utilize these titers. There are 3 papers which I could see where they have measured the rheumatoid factor, anti-CCP, and anti-CCP which were present before the treatment. And what they could see was that the patients who responded to the rituximab, the titers fell significantly in these group of patients, vis-a-vis compared to the group of patients who didn't do well. And in the patients who had responded, and the appearance of the autoantibodies almost marked the relapse of the disease. So probably I think it's only useful in the individuals where they respond, and may also serve as a marker for the relapse. I think it looks like more or less the way we use anti-dsDNA. We may be able to use these 2 antibodies. The trouble with these antibodies is at least anti-dsDNA is quite well standardized. But even again in anti-dsDNA, you might have seen the different labs using the different titers as a cutoff for positive and negative. Some says 10 and some says 100, and some have a value in between. Even there also the anti-dsDNA is also not completely standardized. That's one of the major challenge that we have. See, in the rheumatoid factor also, see, you might have seen some labs saying 20 as a cutoff, some labs saying 6 as a cutoff, some saying 25 as a cutoff. And it again depends on the methods and tests and the processes that they are used. So that being the case, it's only useful if you know the base background. So you have to individualize. If the patient had 1000 international unit earlier, and it comes down to 50 or 100 after the treatment, and it starts scaling up towards 500, the chance of him relapsing is higher.
My thing is, whenever we are doing any monitoring for any of the assays, whether it be a CRP or whether it be any of the tests that we do, ANCA or dsDNA, It is ideally better to use the same equipment or the same lab, the same standard protocol with the same standard. That will be giving a clear picture rather than doing in different labs and then causing confusion. So it's better to follow up in one particular lab, whichever you are doing it. And one platform rather than lab, I would say, which is on one platform would be better.
Ma'am, can anti-CCP become negative following the treatment?
Yes, it is known to become negative.
Okay.
That's what I said. It can become negative, but still we are not using it for, and that it has been known with therapy to become negative, but it's not useful for monitoring.
You see, there are two different ones which you have to work
because
with.
It is not that the values have not really been correlated with the severity of the course. Let me be very clear on this.
It is correlates to severity.
Like this is the severity and this is the...
It doesn't match to the disease activity.
Activity per se.
So it doesn't match to the DAS score, that is disease activity score, but it matches to the aggressive of the diseases over the long term.
So it can, if you do it, it might become negative. So that should not be a concern once a patient has been treated. So it's not like he's positive once he remains positive. Like.
So if the patient is in remission, repeating these antibodies can guide us with the treatment also, whether how long they have.
Yeah. I think we had a still half-completed study from our center that we could very clearly see that many of the patients had a negative anti-CCP and a low titers rheumatoid factor compared to the baseline. I think we need to see and watch how they progress. The patients who have become negative, how do they behave? A gross observation, whatever, it is still not statistically analyzed or worked with. The patients whose rheumatoid factor remains positive, despite achieving a remission, her chance of relapse is much higher vis-a-vis compared to the person where the factors become negative. ACP negative, and there are one or two papers which supports this particular observation. So in all possibility, the answer to that question is yes. I think if you are withdrawing the drug, probably you should reach a point where you are completely stopping the medicine. I personally suggest, I mean, there is no recommendations. I mean, it's personal perception with whatever the literature available and what I have read through. It's best to check once whether rheumatoid factor and anti-CCP status. If they are persistingly high, so it's best to maintain in the lowest permissible dose for him for a longer time. If they are negative, one can dare to withdraw the drug for a period of time, see if he relapses.
So even if they are in remission, we can, and the titers are high, we can stop the medicine or?
No, I suggest to continue the medicine. If the titers are high, even if they are in a clinical remission, even for a year or a year plus, it is best to keep the drug at least lowest drug where the disease is inactive. But of course, as I said, we don't have enough proof. Maybe we should be able to get it down the lane over the period of time.
Sir, one practical thing, like if mother has RA with RF positive and anti-CCP positive, daughter is scared and just got randomly her RF done. It came out to be positive without symptoms. If she comes and asks you what is the probability of she getting RA, is it same as the other population or is it high? How to counsel her?
Yeah, I think the problem one is that she should not have been asked to do the test. Of course, the problem is that people get it done from the home sample collection
then
and continue with that report. Yes,
in those cases, possibly doing an HLA, DR1, and that shared allele testing and all that might. Help. I don't know. That's what.
From the practical standpoint of view, reassure her and keep her on a watch. See, the reason is since her rheumatoid factor is positive, possibility of she developing rheumatoid arthritis increases by 5 times than a SIP whose rheumatoid factor is negative. Okay, so that being the case, what we can offer to her is an early diagnosis and early intervention. See, currently we don't have a methods or a technique or any intervention where I can prevent the rheumatoid arthritis happening. So that being the case, that's one of the reason in the last slide what I presented is, can I use this autoantibody as a predictive? Answer to that question is no, and don't use it. The reason is we don't have a method or a technique to prevent the disease developing. If once we get that particular technique, there is all the more reason for asking a person to spend money and get his things into that. See, for example, there is a point to do a coronary angiogram in a person where you suspect a coronary artery disease, because putting stent gives him another 5-6 years of life. So here I get a rheumatoid factor positive. Do I have any technique to prevent him or her developing rheumatoid arthritis?
We don't have any
Answer to that
prophylactic
question,
therapies, so that means the thing there is
Only
no
means
sense
how
in
should
it.
No.
counsel.
So,
And since she's asymptomatic, you tell her to ignore it.
Just
but the problem
But if
is,
she develops symptoms, maybe you should.
the problem is she doing the rheumatoid factor test and anti-CCP indicates that she has a personality trait of anxiety. Okay, that adds to the anxiety. The rheumatoid factor positive adds to the anxiety. A little more work, a week of pain, she runs to you with that I have developed rheumatoid arthritis. So
that is the problem.
that is the problem. So that's why the insistence is not to do the test. But if they do the test, then I think you have to bear them. We have to work with them to counsel.
Okay, thank you.
I had one last question.
Yeah.
Sir, if any young woman who is diagnosed to have rheumatoid arthritis, but currently in low disease activity, she wants to plan for pregnancy. So doing these antibodies, do they influence their pregnancy outcomes, sir?
No, actually, rheumatoid factor and anti-CCP is not going to help us with reference to planning the pregnancy. So they have no influence on the pregnancy outcome. They have no influence on the way the pregnancy goes. If the disease is inactive, if she is not on any DMRs which are contraindicating for her to conceive, she can go ahead with the pregnancy. There is no need to repeat even the test. There is even no need to repeat the test. Yeah, I think if there are any more questions, not any more questions, I think we will conclude the session. I thank all the participants in the session. Thank you very much. We hope to see you after 2-3 weeks with the next set of discussion on ESR, CRP, and other inflammatory parameters, how to use them. Thank you.
Please give your feedback also, so that we know what is to be done and how we can make this better.
Thank you.
Thank you.
Thank you, ma'am.
Thank you very much.
Thanks.